some of these messages. So to summarize at the moment, how we have it working is the messages going towards the shared health record, the client registry and provider registry are all going to be done in 807V2, and we have specifications for that. One of the ones that we struggled to do was the facility registry, which we could get 807V2 messages. So what we did at that stage is actually go for an XML-based schema. So we have some of those defined as well. So it's basically what we end up having is a mix between some XML-based data representations and some 807 messages as well. I don't know if I have a lot of these. Pete has put together some really good spreadsheets that show exactly what these 807 messages contain and how they map to each of the fields, like this one's for the shared health record. I don't think it's really useful going through a lot of that because it's too technical. But there are certain points that I would like to discuss and get opinions around. Okay.
One thing that might be useful would be to just list the data exchanges that we're supporting. One thing that might be useful might be to list the data exchanges we're supporting and just make sure that people don't think we're missing things that need transaction specifications attached. But why don't we do that after you thought out?
No, that's a good idea. I think we should perhaps stop there. Let me find that.
I'll send it to you in just a second.
So these are just, this is a proper document that's been published, that we've been talking about for a while, and that's the RESTful transaction specifications. This describes the exact API that the interoperability will be supporting to all of the array of transactions. So we have, I haven't been through this previously, but we have, for example, save patient encounter and how to do that, query for previous encounters, the fetching of a single encounter for a patient, registering a new client or patient, querying for multiple patients, getting a single patient, updating that patient's record, then the two called querying a healthcare facility and getting a single healthcare facility, and the same for professionals, querying for a list of professionals and querying for single professionals. And then we also have this one posted alerts, which actually would be posted by rapid SMS to allow us to push alerts to that system. So I think these pretty much cover all array use cases. But I probably
I was going to say, talking to Liz the other day, that's what I thought up till Saturday. Talking to Liz, she put on the table not so much get encounter as get information for a patient, including the relevant information which is stored at the summary level, as well as the information stored at the encounter level. And the other one that she put on the table, which was also new, was correcting previously recorded data for an encounter.
Sorry, just to jump in again.
So I just want those on the table because we need to talk about them.
So those sound like things that are coming more than in the latter session. I wanted to just check with the group, do a quick poll. This space here is where we talk about the provider registry, was the original thinking, and message exchanges with it. Unless we want to diverge this and actually start talking about the wider message specifications.
Okay, so we're just talking about the provider exchange.
Just provider exchange.
So it's the second to the last two.
Yeah, let's start with those weeks. Is there anything we want to get?
Just provider exchanges?
Unless you want to get go straight into the whole message specifications.
Can I,
Okay, so we generally use a place to start.
can I just ask about, is there somewhere where the possible query parameters are defined?
Yeah, those are all defined in this document. That's just the basic summary.
Are these calls available only within the interoperability layer, or are these publicly accessible calls?
These are publicly accessible with security measures. These actually, I can show you these running live. These all are running at the moment through the interoperability layer and are returning mock responses from mock services. So I can show you some of the responses.
You said
So, I just have a quick question, and that is, I see a get and I see a query for professionals, I don't see a put in place or say.
That's
That's because that was in the requirements section, place professionals in through a query.
Okay.
That's only done through curation, through the actual using. Is that your understanding as well?
Yeah, so one thing that, when I was talking to Bob about DHIS last weekend, one thing that came up was the possibility of bi-directional interfaces if another system had a better source of truth. I know that we've not really talked about that, but I'll just put it on the table, you don't say no.
I think that's definitely not within the scope.
How about this year?
Yeah, and I think that you really got to be careful. I think Boris touched base a bit with hard media machine interaction. You can make good data, bad data very, very quickly. And when we're looking at pushing something to registries, it has to be highly regulated from a ministerial level down. Anything less than that, we're looking to the internet. We know how much truth on that.
It's a governance issue more than anything else. It's not a technical issue.
Ryan, are you able to go down to the page that shows what the query parameters are for query for healthcare professionals?
Sure, can do that. Should we make like Paul suggesting, maybe start with professionals and talk through those and then work our way through the rest of them as well? Is that what ideally?
Well, that's actually got still from that line there. The agenda for the afternoon was really focusing on the provider registry. We had some discussions around it and we dealt with that. And the facility registry was planned for after tea. We marked that out. So if we can move into the messaging specifications at this stage, it's a great place to put it. And in addition, we do have some other requests to talk about in February is the infrastructure for the project. What are we really going to be needing from a hardware point of view, as well as some of the capacity plan and a few other sessions that are coming up. So I just want to check with the team if they're happy to move to the next specification environment. Let's move into a round of chips out here and giving us a bit more space to have breakout sessions later on tomorrow, which will be very valuable. And we'll go from there.
I just wanted to let everybody know why I wanted to see that, because if our query parameter set sort of drives us into the arms of having to access HRIS, that's something we might want to know, given that we're in a very tight time frame to circle back with those folks.
I agree. Well, let's start with the provider registry as you suggested, and if there's no complaints about it, let's make this a messaging service section. I think this will probably be one of the sessions, Roger, if you wouldn't mind putting this on record for us. I'm sure many people want to hear about the discussions of this as well as all the communities and connections around the interoperability layer and the messages we have on it.
Yeah, so I think how we run these sessions is maybe just pick a certain registry component or components, one of the service components, and look at their messages. So let's start with the healthcare professionals registry then and work away through them over the next today, tomorrow. Okay, so this is looking at the healthcare professionals registry, part of the. Okay, so we have healthcare professionals registry looking at querying for healthcare professionals. This case for the specification or the transaction specification, we're looking at querying for multiple healthcare professionals, providing a variety of parameters to restrict our search. So, following a RESTful pattern, we have just a GET request to the following URL with certain query parameters attached. All these query parameters are pulled out of the requirements documents. Some of them are quite lengthy. I think this might be one that's got quite a few parameters that are possible. So you can see here the parameters are starting to be listed. Everything that can be in the query parameters section. So we have query by ID, given names, dates of birth, gender, address, various other things, their qualification, education level, etc., current employments, and hours per week they work, etc. All these come from the professional registry requirements that were set out. Do people want to go through this in a bit more detail and have a look at each of these, or do we want to skip straight to the actual specification of the response message?
I guess for me, it's hard to make specific criticism of the attributes. I'm presuming that the ministry said these are the attributes that we need to do. Like, for example, I'm having a hard time conceptualizing why someone would need a number of hours an employee was. But that's what we're asked for.
Yeah, I think my thought looking at this list again is we need to go back and for each query parameter explain the circumstances which will be used.
So something I did for the facility registry, because that also had a lot of these query parameters that also may not really be as useful anymore. Because, so I went to actually put those into different sections and say what is absolutely necessary for some of the right transactions. And that came out to only to be a small few. So then perhaps we could do that same thing for these transactions and also restrict these to exactly what's needed for our use case and not have to support such a large list of parameters so it just gets confusing.
Well, I would say today, looking for September, the only one that would be required would be the ID. And the other one are all of them.
To validate the incoming messages.
Yeah, exactly. Since we're talking about capturing clinical data and validating, is this a real provider? We expect the clinical system to have it.
Does that ID exist in the system?
Yeah.
Have we agreed that validation is the primary use case for September? There's no translation.
Do most healthcare settings understand the IDs of their providers? Is that a notion that is understood?
And I'm asking this in general now too. This applies to the provider registry, but I think I haven't heard of this. That's the question.
In the healthcare setting, do providers generally realize that there's an ID that's assigned to them? Is that something that you all have done independent of what we're doing technically? Like, do you as a clinician know that there's a provider, there's an ID that's assigned to you that's related to you?
No, because there isn't.
So there is no such thing as an ID?
But no, the only number you get is if you are an employee of the through the municipal service, which is not public. When you go to your bill, you get the what you call nominal key, which is a certain number. Very often no one don't remember.
Right. So they're largely ignorant to that. Then.
Yeah.
Yeah.
There is a professional registrations for nurses and doctors.
Yeah, but
So most of them don't know. So when we field tested before, so people do not know they are.
in fact, most nurses are not yet registered. There is a big problem with that. That cannot be used.
We use person-centered.
It shouldn't be valid.
National identity.
But when we do an encounter in OpenMRS, and there is a clinician who is assigned as the principal clinician for that encounter, will open MRS store and ID for that person. I think that's the relevant question. And if the answer is yes, then our setup makes sense. If the answer is no, we shouldn't be validating the position of clinicians at all. That's my opinion.
Well, one of the other truths here, though, is if there's a local ID that's been assigned by OpenMRS, the role of this registry is also to resolve that with an enterprise ID. When you write a shared health record, it's going to have to be referenced and keyed by the enterprise ID of the client, the enterprise ID of the clinician, the enterprise ID of the location.
Yes. If we're going to record, yes.
Well, that's the only way of writing a shared health record is a shared health record.
What
Everything else is a location-specific record.
What are the assumptions we're making? Because of course, we know that there are multiple code systems out there. So are we going to presume there's a single code system in existence for the pilot, or are we going to presume multiple coding systems? It's unclear to me what is sort of the grounding premises for the provider registry.
So you're not uniquely today identifying every healthcare provider in Rwanda. So let's acknowledge that first and foremost. And for this use case, in that one district, we'll have to uniquely identify every community healthcare worker and every clinical provider in that environment. You understand what I'm saying, right?
One thing that you can do is identify them by their social security number, which currently everybody has one, but they don't say number. But now, as we populate
the HR information system, we are going to make sure that everybody puts that number. I mean, the facility enters that number for everyone. So that would be used as a unique number because it's really unique.
Right. I just want to make sure that we're going back to what Randy identified before. And Randy, your input would be helpful here. So the rapid SMS application has 45,000, I'm assuming, community healthcare workers registered into it correctly? Correct. And they're registered uniquely in there.
That's where we're going. There's 8,000 there right now. But we just made a decision last week that we would try to use that interface to add the other.
We know that there's a total of around 45,000.
Yeah. So the point is that, at least for the pilot, there are two service areas where people will be generating clinical encounters with people. And one is in the community through the community health worker system. And each of those people will have an ID assigned to them, or will need to assign an ID to them. And each provider that works in a clinical setting will also need an identifier associated with them. And it sounds like right now that's going to be a synthesis of IRIS and rapid SMS. Is that right? For that one district?
Why wouldn't their ID be the NID? That's also what we talked about. The professional was identified by their NID.
That's what we have in the community health worker record, is the NID.
Yeah. Because that's why community health workers when a problem because they already have their NID. And I think that's the only piece of data we have on that number, right?
But I think the registry will need to be loaded with that information. And if that's the information that you want to use as the linkage, then you gotta make that as a mapping to the global ID of the provider and the system. You wouldn't make that the primary key of the provider registry as the attribute of the provider.
Yes.
Does that make sense?
And that is, yeah,
And that's fundamentally important.
Yeah. The national ID, the NID, is not the key of the registry. It is an attribute of the registry.
Just the same as
we have actually never,
uses its
the NID was never going to be for clients either. It was going to be.
it's always been my assumption, yes.
And so that gets to bring full circle back to what Sean said in the first place. If this is going to have a mapping function, that what that means is if what we're sending from rapid SMS or OpenMRS is an NID, then the mapping function says that that attribute maps back to this person and it returns back a value of a different ID that is what gets deposited as the record, the shared health record. Does that make sense? Yeah.
Thank you. But you want to use the terminal patient key for the...
Okay, just contribute to this so that we make an informed decision. The community health workers are identified by both the national ID and their telephone numbers. because we have given them telephones with telephone numbers, and those numbers are assigned to each individual because they have reported to a residence. They can't really use that number. So for community workers, the telephone number is another identifier. But for the rest of the providers, you can't use the telephone number. So the rest of the providers also obviously have the NID. The other unique identifiers you have, or they have, that you rely on is the social security.
So this is your concern is more of a nuance of design than, so I think what we're saying is there are attributes of a person, including their national ID, including their name, their demographics, and hopefully at some point you will, as a lot of countries do, assign an ID to a provider.
A separate number of those attributes.
Generally, that's how this tends to evolve as the system grows. And so, whether you store that ID, so this unique thing that is kind of unique to the healthcare environment, or the primary key inside the provider registry table is a more of an art question. I think the point though is that what the source system is sending is an attribute that describes a provider. Then there's a process of saying, I'm asking for this attribute. I'm telling you it's this attribute, and then that's going to have the registry return back some kind of ordinal thing that goes inside the shared health record. It's not the NID. The NID is not the key. Does that make sense now?
Yes.
Is the NID the key for the patient?
No.
It's an
attribute
generated health number.
Because there are lots of reasons
no
why
one is
people.
going to be aware of it except for our system.
Correct.
Okay, no. That's the way that I had originally understood it. But we were calling the NID one actually stored.
So does that make sense now?
It does, and that's how we're going to be assigning these numbers. Does it mean it will be provider registry generated ID?
So again, this is where Sean's wisdom, he was kind of quiet when he said that there was actually a lot of wisdom when he was saying, because in fact, if you're not ready to start assigning IDs to providers nationally, then you need a mapping function to be able to say, I want to send this attribute about someone, and then it relates to this notion. And as soon as you come up with a way of labeling them appropriately with a unique ID, then you can send that across and you won't be needing that mapping. It will be just passing it through the shared health record. But you're not at that place right now. And so I think you need an additional function of being able to say, I have this provider, and he has this descriptive attribute, which happens to be an NID in this case. What I need return value back for what gets persisted in the database. Does that make sense now?
Yeah, it definitely makes sense. Just maybe something that you could clarify for me is, if you think the actual shared health record, why couldn't it be stored at the end of the policy?
The assumption would be that there may be people who are providers who do not have NIDs.
Not only that, but there can be reasons why people misuse an ID for all kinds of reasons, or they've been misassigned, or so you want a descriptive characteristic to be an attribute of someone, not the ordinal notion of what it means to be that person.
It's like the reason we're wrong with kids.
The same reason, yes, exactly.
That means it should be added requirements on the provider registry to say that it should be able to assign unique IDs.
If that's what you want it to do. I mean, that could be a function of the HR system to do that. And then I can store it as a fundamental attribute of what it means to be a provider. I think you can go either way on it, basically.
I just have a quick question. The idea of us needing to define the IDs in the way we think is right sort of strange to me. I prefer if we were looking at using UIDs or GUIDs that are system generated, because ideally we don't want to be in charge of looking after the IDs. An ID should be an attribute of the person, and the system should create a completely unique ID as long as it needs to be mapped to the shared health record. If we're working together to get data back, the ID that comes out of the SHR should not be linked to any particular ID that we defined, and rather should then look up on the provider registry or the client registry to see just who the person is and in which format she wants it.
So I think there's a couple of ideas floating around together. A national ID, while it is intended to be a unique ID, in this case we're treating it as an attribute, like last name. Right? It's an attribute that you could get to this individual with. The GUID that you're talking about is specifically designed the database and to guarantee uniqueness, right? I would never share a GUID with an end user or have them pick from pickers, right? But in your provider registry, there is a unique identifier that uniquely within the system that you control, you guarantee uniqueness. That's what that GUID is. The national ID is simply an attribute of that particular individual that's used to link them across.
So we're on the same page. So I just wasn't getting that message clearly.
And so that ID is only, professional registry ID only used internally and never exposed to people to point-of-care systems. So it would be used for the shared health record and within the provider registry of yeah.
There may be over time, if you so choose, to create a viewable provider ID that's separate from the NID. You can do that as well. But yes, so
There's that becomes an attribute.
yeah, it's just an attribute.
So, right, I think we're all on the same page. I feel more comfortable if we know.
So does need that. I mean, so that to answer the first question I had, this whole thing started with yes, it needs that. And that we're not sending over the unique ID in the message. We're sending over an attribute that is, I guess, maybe it's the provider, maybe it's the NID, I don't know. I think there's a decision on that.
So what would it be that we use? Because we've been talking about using that for everything else.
Does every provider truly want to be a foreigner coming in, like he was saying, some identifier, there needs to be some identifying number, but it shouldn't be the professional ID. It doesn't be passport number or ID number or social security numbers.
And I think if the way you have the parameter defined, where there's an ID type and value, it gives you a little bit of freedom in that.
And it also is the only way you can ever do a register. And honestly, I mean, that's in an ideal situation, all you need is a game ID, except the ideal situation will only hold most of it. And it's the only way to do a register.
I don't know how relevant it is in this part of the world, but in part of the world that I came from, there was a major resistance in using a publicly available identifier as a person for provider ID because the providers didn't want other providers to be able to look them up as a patient. So they really didn't want other providers to know about them.
Yeah, it's like in the U.S. telling all the providers that they're to register themselves by sharing their social security number. Right? A lot of them are going to be inherently comfortable with that because of the multi-use nature of the national ID. Okay. Does that make sense? I think it's the point you're trying to
We had this discussion 2 years ago or a year and a half ago, and I think the decision was that understanding the risks, the government wanted us to use for identifications. My understanding, originally, we always talked before about the structure where the client registry was just a specialty. You're a patient, or your client or patient, as well as a provider, and using the same ID number. And so I'm not disagreeing with the system or anything like that. I mean, that's one reason we looked at NID as a primary. And then there was a whole way to deal with those that were not. I think it was the passport ID.
And we're
an
not,
application of
we're not changing at all what would be the primary lookup ID, it would be on UI, for instance. It's just that there will be a system generated. Use it, or even that will use the indices for when the price of the ship.
So, Ryan, just going back to the tag here on the screen, one question has got application ID. How do you identify the application? So I will come back to you NID, which we know is accepted, but it could be a range of different applications. So you have multiple tags to say this is the application ID and then that's the ID for the user entity.
No, application ID is those waiting for their NID. You get a unique number.
So every provider is that. Then we should really understand is evaluate that as an OpenMRS ID or a Rapid SMS ID or a Box EM1 ID coming in.
Okay.
Just to clarify that a little bit, the application IDs.
So basically we'll still be querying on most likely the NID from the API specification, but it could also be other identifying numbers such as social security number, passport number, the NID application number. I had a temporary identification number in there because one stage we had talked about having a temporary ID assigned in case, in some cases.
I think that was still notifications.
I think it was. I think this is probably coming through because of some of the client registry requirements that they had to be removed.
So this presume that every client system is able to store any one of these IDs as an attribute for a provider. And that's what it passes back in the message itself.
Yeah, it seems like the distribution is.
I'm looking at the scenario, I don't know, maybe out of scope, but I want to put on the table so we can get the evaluations. What if you have a system that has its own terminal ID and is able to store its national ID or passing that back? Do we want to look at that use case or it's going to be out of scope?
But we know what systems we're dealing with for this year.
All right.
And we know that they have the ability to store it.
It would be nice to put as a placeholder somewhere.
Our design can't preclude us from ever doing that in the future, but as long as that's not the case, then I don't.
And there might be hostility to systems coming in that didn't have the ability to store IDs. And the hostility is really good.
We were thinking of this as an index lookup, which is how we should be thinking of this, right? This is how we do queries against on index. We've got a number of hours that somebody works. If I ever did a query for that as the only query parameter, I get everybody that works 40 hours a week. That should be well more than half of my entire population of providers. So some of these indices are actually good as indices, and some of these are awful as indices. So,
and I think the rationale behind it, which I'm not sure I could really buy, was somebody might say, give me all the part-time people in this district who are nurses. So I think our requirements deserve to be looked at again.
I think they should too, because obviously if we start to require all these things to be in our index, then we're saying, wait a minute, that use case is against my HR application. Start with the HR application and make the queries against the HR application. That's very different than these are the things that have to be in my index. Because my index by number of hours per week, that's frankly going to create 3 or 4 big groups out of a population of
You don't have to write an index.
You can put an index like it is.
I think what he's saying is not holding.
But I think it's right.
I mean, I think the conceptually using it.
Is that the number of hours a week that fielding is so many?
But we define, there are many query parameters defined. Most of them are out of scope for this year. The question is, among the parameters, are they in scope for any? And I think that's the question, Gary.
So maybe what we should do is just reevaluate some of these queries. Like, for example, querying for healthcare professionals, do we ever need to get a whole list of healthcare professionals returned? Seeing as our rare use case, only querying a single professional to verify that they exist. Do we need to, what is the other use case for querying for a list of them? Is it maybe we can start this out as a...
I think the original vision for that was that there was no HR system, and they were going to make this provider registry serve some of that functionality so that you could see utilization and a number of other things. So I think, yeah, and I agree with the process that we should be able to go through and say, since there is an HRA system, maybe this is more.
Yeah, I think many functions related to HR are going to be carried out by the HR information system. I guess what the provider registry should concentrate on is its contribution to the shared health record. Which goes, of course, to the mechanic files for the providers and so on and so forth. Squaring, who is working where, how many doctors do you have, how many nurses, or which kind of this profession do you have. That is already being carried out by the HR information system.
So, yeah, that sounds good. If that's the case, then do we maybe need to alter our professional registry requirements to not list so many of these parameters as well? Because maybe we could just store an ID, the various ID numbers, so healthcare professional registry ID, then the NID, social security number, passport number, whatever else, other attributes, and some basic demographics, and not have to store all of the all these other demographics and qualifications and education status of professionals. I mean, it simplified it much more.
I think so. The main functions, in my opinion, of the provider registry would be, the contribution to the shared health record, so who treated who, which means you need to know their identification and where they are working. Of course, when you start, like what we said earlier, when you start searching for which services exist in a hospital, you need to know, let's say, if there is an ophthalmologist in a particular hospital, there should be an attachment to where that person is working so that you can make a reference to where the service is offered. Otherwise, anything to do with aggregate data or general, let me say, queries like which kind of specialties do we have and so on and so forth, should be left as a function of HRIs.
But I think we might need it because, for example, we talked about, like example of anemia reported by a doctor versus a nurse versus a community health worker. And if the role does not come along with their ID to establish your health record, you need to resolve it some other way, right? Because it's who contributed the data. They're not just me personally in it, but me with whatever my role is as a physician, as a nurse, or as a community health worker.
Yeah, I think part of the education includes your education.
But education, my role, my whatever
profession.
Yeah,
that's what I mean. Profession. Yeah. Are you a doctor? Of course. I mean, amongst the description of that of the provider will be your names, your date of birth, your profession, are you a doctor, are you a nurse? But there will be no need of preparing the provider registry for a list of all the gynecologists in the country. Right? It's just there so that you are identified as so in the shared health record.
There's not a need for it now.
Well, actually,
even in the future, I mean, all that information you provided in the HR information system. If you wanted to know how many gynecologists do I have and where are they working, the HR information system gives you that now. HR is going to do that.
Okay. I also want to point out that our result set from the query is not the records, it's the lookup IDs. Like, when I say this is very much an index thing, my query returns the lookup keys, right? It's not returning the whole record from everything I can possibly get. So if I did get all the gynecologists in Rwanda and then have to do physically to go through my record, I can go fetch all of their information. It's really, I agree with what you're saying. This is what we use as index queries. We use to support those index queries.
How this was designed to work is that you would query it with that ID, and in return it would be a record, but within that record the ID, the enterprise IDs, I think you'd like to call it. So it would be a record return containing some information as well as the ID that you need to store it. This could be changed if you feel that it's not something you want to support.
Was it expecting to return the entire HR record?
We have,
You could have both.
we have created that specifications to return the record. That is something that's not required by our use cases that was here, but we did it nevertheless.
So the query returns a list of records, or the query returns a list of IDs and the GET returns the record? Does the query return all the records? So it's
This is kind of an engine. I mean, it's
Yeah,
a little bit
I
of creative. You raise a good point, but I'm not sure we designed that.
I mean, I think it's a very small change to have some more private query functions.
So should we?
I think we should.
Okay. Well, firstly, what I did here is just identify some of the things that we actually needed in the report, which would just be to identify attribute IDs, which would be like the NID, social security number, etc. Facility ID, where they're working. So basic demographics, name, date of birth, gender, etc. Role in profession, and possibly education. I mean, can we restrict the professional registry down to rather, instead of having to have the entire list of fields that we have in our clients at the moment, to rather just do this, in light of the fact that we now have a HR system that provides a lot of information.
And then justify adding new attributes as you go. Better to start that way.
Yeah.
I would, yes. I would suggest that we ask somebody to go out, make a proposal for that, look at it for their tourism, if they're in modification. So I think the basic idea, we move forward
Does everyone feel the same way? Feel it?
Okay. Yeah, I think we just decided that, did anybody disagree?
Sorry.
That we were going to pare down, this is going to be all that we have about these.
So what we were just saying is we perhaps in light that we now have an HR system, maybe we don't need to store all the information that we were thinking of doing originally within the professional registry. So maybe we can cut it down to something just like the professional registry ID, the attribute IDs, which would be something like the NID, passport number, social security number, something like that. Where they're working, so a link to the facility registry ID, some basic demographics, name, date of birth, gender, their role or profession, and possibly education as well, and rather restricted to that subset, rather than having all the data that's now covered by the HR system. Is that something you agree with?
One question, higher education.
Yeah, I think it was just mentioned to have a response.
Very, very simple, very deep.
Okay, and then also in terms of the messaging specifications, perhaps something that Derek was saying, maybe we should just return, have a single endpoint that rather just returns the enterprise ID instead of returning this full record, or actually have both, maybe, because I think both would probably be useful. And it's not a big effort to make the change.
I agree. I think just to echo what Chris said, yeah, this is a design and requirement change we're making that we formalize and get a few to resume the teams in this cycle very, very quickly. So, could try to do some of this overnight, some of the weekend. Verbally, you have the decision, these are the fields that are going to be returned and stored in the provider registry.
Well, I agree. We have to keep it as simple as that was. The Asian functions is very good and the rest of the queries. Maybe you have a school education monitoring for those who are still practicing. When you look at the medical record, the summary record, would you rather know if someone who made a comment to the patient's file is a gynecologist or surgeon, or whereby professional can you find out, or professional say a doctor and a nurse? We each looked at detail of saying you're actually a surgeon or a gynecologist or a pediatrician. I'm asking that question so you know whether the profession is good enough to define someone's role and give that extra information about your capabilities, your expertise, or if you should add that addition to what you have there.
Is it going to make a difference in the writing to what Rich is describing now?
Okay,
My specialty is opposed to just my gross role, whether it's physician, nurse, school, or worker. My subspecialty is detail decision.
Clinical is the argument as a doctor. Do you want to know if someone who did this is a scientist or a pediatrician
Or
midwife?
I think you should probably have
Instead of saying nurse, doctor, pediatrician.
Yeah, level of education and their specific role, I think, are two different things.
So education is going to be part of it.
We actually just, better when we had the community health worker discussion, we talked about the difference between role and profession. So you may play a role or was the word role there?
Well, there's
Yeah.
system roles, like you could supervise other community health workers, but you could still be a community health
Right,
worker.
that's your role versus your profession or your function being different in your education.
I think so.
Yeah.
So do we need to capture, we need to capture education. I might be a doctor, but I'm acting in the capacity of a nurse.
Yeah. That's not going to happen, but I mean,
I was going to say the reverse.
sorry. But the general idea definitely holds true. That the level of training you have might have a role in what you actually do.
So do we need it in the provider registry, or do we just need it in the HRH system?
Or do we need it in the shared health?
Yeah, does it have to go to the shared health?
I think what you said would need is the ID of someone.
Also, this qualification.
So when we return the data,
For the qualification of community workers, the education, it is also captured in the other system. I don't know if it is also being replicated in the provider registry because the other WSMS and MOSMA systems is already captured. And for, I think, for human resource commission system is also captured. The specialty of providers, they are A2, A1, they are specialists of them. For that, all the specialties are going to be dated, I think.
I think let's just keep it simple. If we have those information plus someone's specialty with that, we'll be pretty good. I'm looking at this as what would rather want to see in a summary report. Okay? In terms of the provider, if you can get their role and their specialty, that's good enough, I think. If you want to provide continuous care to the patient, that's all you need to know. So by keeping it very simple, good. Plus, since you're now cutting down instead of adding on,